still get this arousal response, and it's quite dramatic, and it happens quite quickly. So this animal also was under isoflurane anesthesia for at least 40-45 minutes. We let them equilibrate for a long time. The isoflurane has not been turned off, and just by stimulating dopamine neurons in the VTA, we've been able to induce this arousal response. Sometimes it takes a little while to kind of get it revved up. It's not quite as potent as the electrical stimulation, but as you can see, it's certainly sufficient to induce arousal. The righting reflex is tricky in these guys because they have this big heavy thing on their head, so it's not easy for them to flip. But as you can see, he's waking up. And so I hope that I've convinced you that methylphenidate and dextroamphetamine induce reanimation by activating a dopamine-mediated arousal mechanism, and that this actually may be useful in the operating room to induce reanimation in surgical patients. If you have a delayed wake-up, if you have a patient who has a big neurospine case, an 8-hour case where you can't use muscle relaxants and you have to have them under deep propofol anesthesia for 8 or 9 hours, those patients routinely take like an hour to wake up. And you don't have an end tidal, you have no idea where you are with the propofol. As Matthias mentioned earlier, we don't have target-controlled infusions yet here. So it's kind of a guessing game, especially with propofol. And as I've showed you, these drugs can reverse propofol anesthesia too. We also think that it might be useful as a safety valve. When you induce a patient with propofol and you can't secure an airway, this, giving methylphenidate or dextroamphetamine may potentially wake up that patient faster before they desaturate. Electrical microstimulation of the VTA induces reanimation from isoflurane and propofol anesthesia, and I don't think this is going to be particularly useful for anesthetized patients, but perhaps this kind of technology could be used in patients who are suffering from coma or vegetative states, where deep brain stimulation is now being used more and more for Parkinson's disease. Maybe we can start using deep brain stimulation of these arousal centers to try to treat patients who are in comas. And finally, the optogenetics experiments suggest that it's about as clean as it gets, that this really is a dopamine-driven process. And I think that hopefully this will create more interest in looking at the role of dopamine in arousal. So I'd like to end there, and thank you for your attention. These are my collaborators, and if you have any questions, I'd be happy to answer them. Thank you. Yes, Mervyn.
So,
yeah.
Great work.
Oh, thank you.
So, it seems like the norepinephrine effect was necessary but not sufficient, right?
Yes, well, we actually, one thing I didn't mention, we did have another paper where we used dopamine agonists, and we found that we actually did get arousal with those. EEG effects weren't very pronounced, suggesting that those EEG effects are probably driven more by norepinephrine, but the behavioral effects are probably being driven more by dopamine.
Have you tried to dissect the receptor subtypes that are involved? Because, for example, with the atomoxetine,
yes,
you're getting release of norepinephrine that's going to act on both alpha-1 and alpha-2.
Sure.
So whether, in fact, you can see whether eliminating the alpha-2 effect, you can get an alpha-1 arousal effect from atomoxetine.
That's a great question. I haven't tried that yet. We haven't tried anything more specific, but it's a great question because you may actually be doing a push-pull. I see what you're going with the atomoxetine. One receptor may be driving sedation and the other one might be driving arousal. So it's a great question. And I think one of the things about dopamine and norepinephrine is that, like with Max's study with the DBH knockout mice and things like this, people have been trying to dissect dopamine and norepinephrine and what's doing what in the brain. And it's very difficult to dissect these because norepinephrine is produced from dopamine, and dopamine beta hydroxylase is the enzyme that converts dopamine to norepinephrine. So you can use dopamine beta hydroxylase knockout mice like Max did to basically take norepinephrine out of the brain and see what happens. But there are always compensatory changes that occur, and it turns out that those DBH knockout mice are actually hypersensitive to the effects of dopamine. And so it's very hard to tease these two things apart. And we've tried in our own way of looking at waking up from anesthesia to see if stimulating these pathways causes differential effects. But I think there's a lot more to be learned about what these neurotransmitters are actually doing.
Here in the front row.
Yes.
Did you measure the respiration when during the drugging?
Yes, so in our first study using methylphenidate, we actually did some plethysmography studies. And what we found is that methylphenidate consistently increased the respiratory rate and the minute ventilation in our animals. So what we did in that study is because we didn't want the animals to move around, we increased the dose of isoflurane to a point where the methylphenidate no longer caused behavioral arousal. But even under those conditions, they still breathe faster. The minute ventilation went up. We used arterial blood gas and showed that the PaCO2 goes down. And when we gave droperidol before the methylphenidate, it completely blocked that effect, suggesting that it is a dopaminergic effect. There's also, I don't know, I can't remember which one, but there's an investigator named Peter Lally who's published several papers on dopamine agonists and how they increase ventilatory drive. It's one of the questions that we're interested in looking at further and really trying to dissect that pathway and figure out, because they seem to be clearly interconnected. And I think especially this audience, I'm sure, is interested in the respiratory drive. But
dopamine is, I think, it was the healthy body.
yeah, it's probably that, but I don't think the neural mechanisms are really well understood of exactly which projections are doing what. I think that we still need to try to tease those apart. But it is known that dopamine drives respiration. That's definitely known. Other questions? Yes?
Fantastic.
Oh, thank you.
Talk. I'm probably not as awake as maybe some other people. I've just got playing from Australia.
Oh, wow.
But any work on naturalistic experiments in human beings, categories, I've done a lot of work with people using recreational stimulants, also in the operating theatres. I don't know whether your ENT surgeons use cocaine here routinely for dose preparation.
So there's some case reports, that we're seeing more and more of these kids who take these drugs for ADHD, right? We're seeing them all the time. And there are case reports that suggest that if someone takes these drugs like methylphenidate or dextroamphetamine, which is the main ingredient in Adderall, that those patients, if they take the drug on the morning of surgery, it takes a lot more propofol to put them under anesthesia. In fact, the person that I share my office with, who's also an anesthesiologist, said that he was trying to do routine GAKs with an LMA, and it took 400 of propofol to make this patient actually be sufficiently deep so he could put the LMA in. After 200, which is usually a standard induction dose, this patient was still moving around and looked kind of half awake. And it turns out the patient had taken their Adderall that morning. And so, if you look at it from the flip side, if you're on these drugs, it takes a lot more anesthetic to go down. So that is consistent with this concept.
I guess that seems to be, are we going to get to the stage where we start introducing these drugs more for post-op pain, which might also have these beneficial effects, the way our colleagues in palliative care have been using stimulants?
Perhaps. There was a study in the 80s that found that methylphenidate doesn't seem to enhance analgesia at all. The opioid requirements didn't change. But it is something that certainly be interested in studying. We actually just got FDA approval for the use of IV Ritalin in surgical patients, and we're actually just got IRB approval to test this concept and see, can we wake up patients faster from general anesthesia with these stimulant drugs in humans? So please stay tuned. Hopefully we'll have some interesting data to show.
Any thoughts on, say, do your surgeons use cocaine in Europe, or has that gone out of?
To be honest, this is kind of unique to us, but Mass General doesn't have ENT. It's actually it's called the Mass Eye and Ear Infirmary. There's a whole separate hospital right next to Mass General. So we don't do any ENT cases. So I really don't have a lot of experience with patients on cocaine.
I guess you might not necessarily, because you're saying there was a disconnect between.
Yeah, this was kind of a weird endpoint. We're still trying to figure this out because, the EEG looked almost identical, and yet the behaviors were markedly different. And so I think there's still a lot more work to be done. Yes?
Regarding what you just commented on, are you pretty sure that little guy didn't have a locked-in syndrome?
So you never know.
No arousal, but do you know for sure that he wasn't awake?
I don't know for sure. This is the problem with using rats and the writing reflex, especially when you start putting heavy things on their heads. It's really not a great endpoint. One thing we'd like to do is have more sophisticated cognitive testing, see how much cognition comes back and things like this, which is really hard to do in these animals.
I guess I don't know enough about the anesthesia to know if there could be a differential effect, in one part of the brain versus the other. The cortex may be turned on.
Certainly could be the case.
And elsewhere, maybe,
And like we've used, for example, we did some experiments that we haven't published yet using physostigmine, for example, which increases cholinergic neurotransmission in the brain, presumably would increase arousal. And what we found is that it actually took rats longer to wake up from isoflurane using this assay when they got physostigmine. And I think it's because it caused muscle weakness. And when you have muscle weakness, they can't flip over very well. And when your endpoint is flipping over, and you've caused muscle weakness, it kind of gets to the point you're saying is we may have caused cortical arousal. They may be awake, but just not able to flip over. I mean, giving physostigmine is kind of like giving Sera nerve gas, right? I mean, you get that whole body muscle weakness. So it kind of emphasizes that these, there's a limitation to all these endpoints that we use in animals. And so we're going to try to use more sophisticated methods to really look at brain function.
Richard, last question.
Yes.
I was just a comment. So I
Yeah.
would think that sensory evoked potentials would be a way to assess whether there is awareness.
Sure. Yeah, no, it's.
Which can be picked out with a sound and multiple samples from the EEG, which you're measuring anyway.
Yeah, sure. Yeah, no, that's a great idea. No, we should try that. Thank you.
Okay, on to the last question. The last word.
This drug, Provigil or modafinil, it's not to work through drug there's
Yeah.
controversy about it. Have you looked at this?
Sure. Yeah, so we put it on the list at the beginning. I actually did try it in one rat. The problem with modafinil is that it's extremely insoluble in aqueous solution, and so getting it in solution is very tricky. And so I started looking up like how people put it in solution, and it turns out most people use ethanol. And so I stupidly gave modafinil dissolved in ethanol, and then I realized, oh my God, I just gave a general anesthetic with it. So of course they're not going to wake up. The other problem with modafinil is it's really expensive when you get it pure. It was $75 for one rat dose. And so, when I started doing these experiments, I kind of didn't want to go for the most expensive experiments. And it's an interesting question. Yeah, now I can start looking at it. Now things are better. But it's an interesting question, but it is one of the limitations. We could do DMSO. That's kind of another approach. But we've been sort of more. We've kind of focused more on the pathways. Like we really wanted to dissect, like what's going on in the brain, as opposed to just, trying different drugs. But it is a drug that we would like to revisit. We kind of wanted to use drugs that are mechanistically more well-defined, though.
Maybe one way to sort out mechanism of action of the drug.
Sure. Yeah. No. Absolutely. Because I know there is controversy about that. Yeah.
Okay, and with that, I think we'll close the session. Thank you all for coming. According to the schedule, there's a reception so we can wake up to go kill a few brain cells.
Great. Thank you, Mark. Yeah, no, I enjoyed your talk as well. Thank you. Chris is doing great.
You gonna hang around for a while, or what?
I think so.
Settling down in there.